vast topic. Anyway, I'll try to. So first, glomerular diseases. Now, in tubular disorders, the hallmark is salt pasting, but in glomerular disorders, the hallmark is hematuria, especially in glomerulonephritis. But in glomerular disorders, you'll have a lot of asymptomatic. There are how the patient can present in any way: asymptomatic hematuria, asymptomatic macroscopic hematuria, nephrotic, nephritic, RPGN, and chronic glomerulonephritis. We can present in any way. Now, these are the 5 types. See, in asymptomatic, what happens is, the protein can be up to 150 to 300. Okay, and hematuria can be more than 3 RBCs per hyperfield, or more than 3 RBCs per hyperfield in 3 different times, and also more than 10 RBCs per hyperfield in one occasion. Macroscopic hematuria, you'll have brown red painless hematuria, typically which coincides with infection, and the most common cause with macroscopic hematuria is IgA nephropathy. Now, nephrotic syndrome, as we know, you'll have proteinuria which is more than 3.5 gram per day, and albumin will be less than normally albumin is less than 30 milligrams per day, but here albumin will be less than 3.5 gram per dl. You'll have edema, hypercholesterolemia, lipiduria. Apart from that, you're not going to see 24-hour urinary protein, right? So spot sample urinary protein loss will be more than 2 grams per gram urinary creatinine, and spot will be less than 2.5, and oncotic pressure will be less, will be edema. And apart from that, you'll have loss of ferritin and ceruloplasmin, which is an example of non-selective proteinuria. And nephritic syndrome, you'll have hematuria, you'll have oliguria, proteinuria will be less than 3 gram, edema will be there, hypertension will be there. And chronic glomerulonephritis, you'll have hypertension, renal impairment, proteinuria, and shrunken smooth kidneys. So we have a nephrotic and nephritic. Mainly we're going to focus only on that. Nephrotic and nephritic. See, for nephritic we have RPGN, IgA nephropathy, and post-septococcal glomerulonephritis, and we also have membranoproliferative glomerulonephritis. In nephrotic syndrome, we have only 3 disorders, which is minimal change disease, FSGS, and it is our membranous nephropathy. Now, before going to that, you have to know one thing. The proteinuria, how do you suspect if a patient is having which type of proteinuria with respect to protein? See, normally the fetal serum protein is 6 to 8 grams. It's very important. Anyway, there will be about less than 150 grams per day protein loss in urine. But if the protein loss is between 30 to 300, you have to suspect DHEM, hypertension, and glomerulonephritis. Here, 300 to 3500, 3.5 grams, 30 mg to 300 mg. Here it is 3.5 grams. You have multiple myeloma, congestive heart failure, fever, exercise, and postural proteinuria. If it's more than 3.5, don't think nephrotic first. Always think DM, amyloid, and then only nephrotic. After also myoglobinuria and HbUrea. Now we know more than 3.5 is always nephrotic. More than 4 is amyloidosis. More than 10 is multiple myeloma, hemoglobinuria, and myoglobinuria.